One mistake that the reintegrative therapist makes, that the conversion therapist also makes, is that they both assume trauma symptoms are present with every client who experiences same-sex desire, pushing, even subtly, a theory on a client who doesn't believe they have a trauma history is at best disrespectful and at worst coercive. So I wanted to understand the degree to which reintegrative therapy's approach would provide something altogether different from Nicolosi Sr.'s approach after I'd witnessed the negative consequences of conversion therapy for over a decade. Also a model that hasn't been shown to be effective. Some use of kind of aversive techniques, things like kind of mocking voice inflection. And I've sat with many clients who share the ways conversion therapy metastasize shame and fear around their attractions. And many of the providers offering reintegrative approaches, I think, are lacking in some of that ethical, competent care. Large-scale, longitudinal evidence of reintegrative therapist claims may come, but it doesn't exist from the current research available.
Okay, let's talk about this. Hi, I'm Andrew Rodriguez, and welcome to Psycho Bible, babbling about psychology and theology. And a little over a month ago, a Catholic psychologist named Julia Sadusky put out a couple videos attacking reintegrative therapy, or at least giving all her reasons why she doesn't support it. So briefly, real quick, who is Julia Sadusky? She is, I guess, a fairly well-known name in Catholic circles, kind of thought to be like a leading voice in how to navigate sexuality and gender-related issues and your Catholic faith. She's also growing as a big name within evangelical circles because she co-authored a couple of books with Mark Yarhouse. And she even presented last year at the American Association of Christian Counselors big world conference on her book that she co-wrote with Mark Yarhouse on navigating gender issues. So she's got a lot of clout, apparently. And if you go to her website, you can see her recommended resources, and you'll see she's heavily associated with Side B approaches, such as Preston Sprinkle's Center for Faith, Sexuality, and Gender, the Catholic Ministry Eden Invitation, Equip, the Revoice Conference, and then Kaleidoscope Ministry, which actually seems to be like a mix of Side A and Side B gay Christianity. So in other words, she's not some nobody, and she seems to be pretty well connected. You can do a search for her and find she's been interviewed by a lot of different sites and a lot of different influencers and organizations. So she's kind of sought out as the Catholic Mark Yarhouse, I guess, in some ways. So whatever she says has a lot of weight. So it's a pretty big deal when she puts out a video saying why she does not agree with reintegrative therapy. Now, it's been over a month, and this is still the only video on her YouTube channel, or at least the only public video. She apparently has more, but my hunch is they're unlisted, so she probably makes them available only to her patrons. So it's very interesting that she decided to make this her one video that's public, and her first video. And the same exact day that she released this video was the same day that an interview she did on another YouTuber's channel, Gay X Trad, came out, and they were discussing the same topic about reintegrative therapy and how to help individuals in the Catholic Church navigate same-sex attraction and reconcile that with their faith. Very interesting platform to be on, because Gay X Trad is a very Side A gay-affirming individual. And apparently it was Gay X Trad's production team that filmed her video for her own YouTube channel. So the two videos go hand in hand. So this all smacks of a concerted effort to discredit and really defame reintegrative therapy, not to mention the Nicolosis. Just look at the thumbnail she created for her video on her channel. Should Catholics do conversion therapy? While the video's title is Why I Don't Do Reintegrative Therapy as a Catholic Therapist. Clearly making the conflation between so-called conversion therapy and reintegrative therapy. And I can assure you that she never reached out to Joe Nicolosi Jr. or any of us other reintegrative therapists to hash out her concerns before going public. And she hasn't responded to efforts we have made to contact her after her videos came out. So I'm not so confident that she's engaging this topic in good faith. but I don't want to be guilty of doing what she did to the Nicolosis in her video and assign motives to her. Nor am I going to use any personal attacks and bring up any dirt that might be out there on her. But fair warning, I might get a bit snarky. Okay. Actually, as I was doing editing, I realized I wasn't so much snarky as I was angry. The more I was watching her videos again, the angrier I got, and it really did show, as you'll see as you watch this video. I thought about re-recording those sections, but that would just be way too long. So I just want to apologize in advance. Longtime viewers know I'm usually pretty chill. I can be pretty pointed and blunt, direct, and even confrontational, but well composed normally. So I'm afraid this might not be my best foot forward, but the points I'm making in these sections where I'm angry still need to be made. So if you can bear through my tone a little bit, you'll hopefully hear what I'm saying. All right. It's not my style to go on the offensive, but I'm sick and tired of people, especially fellow Christians, attacking my colleagues and I in the sexuality counseling world and ex-gay ministry realm, slandering us and the work we do. For a long time, we've taken attacks lying down. But a few years ago, especially after the Netflix faux documentary Pray Away came out, and a bunch of influencers in the Christian world threw us under the bus, I've taken the gloves off. So if you attack my colleagues and me doing good work, expect a response from me at some point. Now, full disclosure, I am a certified reintegrative therapist. I also had done some prior training with Joe Nicolosi Sr. in reparative therapy, actual legitimate authentic reparative therapy, and worked under him for a period before his untimely death in 2017. I then did more formal training with his son in reintegrative therapy starting in 2020, and I'm now a certified reintegrative therapist, and as of this year, I am the training facilitator for reintegrative therapy. So I will be the one conducting our trainings for new therapists, both in basic level and advanced level in reintegrative therapy. So I'm not coming at this from a completely neutral place, but I also want to make clear that what I'm saying here is not the official response from the Reintegrative Therapy Association or the Nicolosis. These are my own thoughts, my own words. That's just how I operate. I always say what I think. So I'm not saying this as a representative of the Reintegrative Therapy Association. This is my own YouTube channel, and so these are my thoughts. So just want to make that very clear going forward. So let's get into her videos and address her criticisms based on their merits or lack of. We'll primarily be using the video that's on her channel. We'll just walk through it because it's only about 24 minutes long and I got a lot of notes. So we'll walk through that using that main template, and I'll throw in some aspects or clips from the other video, the interview with Gay X-Trad. Fair warning, this video might get a little lengthy. Like I said, I have got a lot of notes for this one, because really what her videos really demonstrate is how much misunderstandings there are and really ill will toward those of us doing reintegrative therapy, toward those who did actual Nicolosi Sr. trained reparative therapy. And so I can understand some of the confusion that's out there, and so I'm taking this video as an opportunity to clear up some of that confusion. There's also a lot of judgments made, a lot of falsehoods made in her videos. So I will be addressing those head on. And I'll say this right out the gate. We're not perfect in the reintegrative therapy or past reparative therapy world. We're open to criticism. We're open to adapting and improving. But criticism must be based off truth. And what you see in her videos and her commentary is a lot of conjecture, hearsay, misunderstandings, and misinformation in her videos. So we're here to call the shots as I see them. And the misinformation comes early, so let's not waste any time, let's get into it.
Lately, the phrase reintegrative therapy has been coming up regularly in conversations with my Catholic clients and friends. This therapy has also been promoted in recent interviews by prominent Catholic influencers, increasing its visibility in our circles. Today, I want to walk us through what reintegrative therapy is and examine a few of the key claims of this form of therapy to explain why I do not use it in my clinical practice or recommend it. I'm a licensed Catholic clinical psychologist working in Colorado, and I've been researching sexual and gender identity development specifically for people of faith for over a decade. I earned my undergrad degree at Ave Maria University and a graduate degree at Regent University. So, what is reintegrative therapy? Reintegrative therapy is a new therapeutic approach that, according to its developers, uses established evidence-based interventions, the same interventions used by other clinics throughout the world to treat trauma and addiction. As these dynamics are resolved, the client's sexuality can sometimes change on its own. Joseph Nicolosi Jr. is the founder of the Reintegrative Therapy Association, which has been promoting this approach since it became a 501c3 in 2017. The claim of reintegrative therapists is that they're offering an approach that is entirely separate from the controversial approach of conversion therapy. They define conversion therapy as any attempts to increase heterosexual attraction and decrease unwanted homosexuality with the help of, as they say, a usually unlicensed therapist.
She misquotes the Reintegrative Therapy Association's statement on conversion therapy, adding in or replacing some words with "is any," when the actual statement is referring to how critics refer to conversion therapy, what they mean by the term. The actual document from the Reintegrative Therapy Association's website says conversion therapy is a general term to describe attempts, and so on and so forth. This is very different from what she's portraying. She's going to then use this truncated definition against us throughout the remainder of her video. So it must be made clear, we're not saying that all of these things that are considered by the world conversion therapy necessarily are conversion therapy, but just that the world uses the term conversion therapy as a catch-all for all sorts of things, basically to prove our point that the term lacks a clear definition and a consensus, and it's not one that we own ourselves.
This definition of conversion therapy would include the approach known as reparative therapy, which actually gained prominence through the work of Joseph Nicolosi Jr.'s father, Joseph Nicolosi Sr.
See what she did there? She's going to spend the majority of the video trying to make it look like Joe Nicolosi Jr. is throwing his own father under the bus, labeling his own father as a conversion therapist. Now, to be honest, I actually don't think Joe Nicolosi Sr. minded being called a conversion therapist. The term didn't have as much of the negative connotations when he was alive. At one point, his website even said, quote, "This is the website of Joseph Nicolosi, the father of reparative therapy, also known as conversion therapy," unquote. I know some people advised him against accepting that label, but based on my encounters with Nicolosi, I believe he did it to cast a wide net. He just wanted to help as many people as possible. So if the public was going to use the term conversion therapy to describe our work, he was going to utilize the term to bend the algorithm his way. If people are going to type in conversion therapy in their search for counseling for unwanted same-sex attraction, he probably figured using that term was the best way to make sure they got the right information. He didn't care about being politically correct. He was a New Yorker at heart. He just told it like it is. So, hey, people aren't going to like me and they want to label me a conversion therapist, so be it. Whatever gets them in the door. That's how I sort of perceive what his attitude was in using the term in the very minimal way that he did. But he is not the father of conversion therapy. He is the father of reparative therapy. People want to use that term interchangeably with conversion therapy, but you can't, because what we see now is the term conversion therapy being used so broadly that it doesn't match anything what Joe Nicolosi Sr. actually created. It's sort of like how early Christians got their name. The term Christian was originally an insult. Before that, they were called followers of the way, or believers, or disciples of Christ. It was in Antioch that Christian, little Christ, was used in a derogatory way to label us, and we ended up just embracing it. So I think that was Nicolosi's approach to the term. Didn't really care if it was derogatory or if it was a pejorative for what we do. It got people in the door. He was able to capture them that way. But the problem with embracing conversion therapy is it's too broad. The early church hashed out its definition of Christianity, so not everyone who referred to Jesus could be accepted as a Christian. So if conversion therapy was a term with a precise definition and ruled out methods that involve coercion and aversive techniques, and if it applied only to practices by professional mental health clinicians who can do actual therapy, if we had the authority to declare what counts and what doesn't count as conversion therapy, most of my colleagues might not mind being called conversion therapists. Footnote though, I would either way still take issue with the term because it presupposes the sexual orientation paradigm, hence the false idea of converting someone from one orientation to another. In fact, when I first heard the term, I was in graduate school, and despite several years of involvement in ex-gay ministry and counseling, or in a lay counseling setting, counseling guys who were leaving homosexual lifestyles or coping with unwanted same-sex attraction, I had actually never heard the term conversion therapy. So when my classmates called me a conversion therapist, I was confused. I thought people were referring to treatment for conversion disorder, which is something completely different. It's a psychosomatic condition. All right? Anyway. But since the term is used so broadly that it includes any and all techniques and approaches for unwanted homosexuality, my colleagues and I repudiate the term. So, when Joe Nicolosi Jr. contrasts reintegrative therapy from conversion therapy, he's not distancing himself from his father's approach of reparative therapy, but from the straw man of his father's approach that people lump together with all other conversion practices. And we have every reason to distance ourselves from the term conversion therapy. Just look at how it's used in our culture. Most of the time, they're not referring to therapy at all, but things like self-help, listening to preaching, reading books, or even barbaric forced sex change operations in certain Muslim countries, such as Iran, all get called conversion therapy. And that's just not fair. Or just ultimately proves that the term is untenable. Take a look at this clip of Jennifer Lawrence at a gay awards show.
Love the gay community. In fact, I was in love with a homosexual. It was my first love. I tried to convert him for years, but now I know conversion therapy doesn't work. Did you hear me, Mike Pence? I said conversion therapy isn't real, even though I know you think it worked on you.
She said that she tried dating a gay guy, and because he didn't change his orientation, conversion therapy doesn't work. That's like saying she's dating an alcoholic and tried to sober him up, but he wasn't down with the program. So she concludes professional drug and alcohol recovery doesn't work. The best way you can show that you're engaging this topic in good faith is using accurate language. Conversion therapy is so broad that it's a useless term. Legally, the first term used in the bans against professional therapy for same-sex attraction for minors was SOCI, Sexual Orientation Change Efforts. They've since expanded that because they need to also make sure they ban counseling for people or adolescents with gender identity confusion. So they've now called it SOGIC, Sexual Orientation Gender Identity Change Efforts. So they keep having to expand it. So then they use the term conversion therapy as a blanket for SOCI and SOGIC. But the SOCI term is also misleading and can be generalized to include non-therapeutic efforts. So, in 2016, the Alliance for Therapeutic Choice and Scientific Integrity adopted the term safety sexual attraction fluidity exploration in therapy. And yes, I know it's a mouthful. Which includes all professional therapy approaches for exploring sexuality change, but excludes non-therapy approaches. Reparative therapy and reintegrative therapy can be considered specific types of safety, just like we have narrative therapy safety, psychodrama safety, cognitive behavioral therapy safety, internal family system safety, etc. So if you want to be most accurate and respectful, call Nicolosi Sr. a reparative therapist and Nicolosi Jr. a reintegrative therapist, because that's what they actually are. You discredit yourself the more you use conversion therapist without qualification. In her interview with Gay Xtrad, she gives this characterization for so-called conversion therapy.
So today we're talking about conversion therapy, reintegrative therapy, and reparative therapy. Can you kind of walk us through what are each of those buckets and the theories behind them?
Yes, so it can be really difficult to identify what we're talking about when we talk about conversion therapy versus reparative therapy versus reintegrative therapy. And there are some similarities, but there's some important differences. So with conversion therapy, what we find is an assumption that attraction is kind of like a light switch that we can turn on or off through therapeutic intervention. So the goal is using therapeutic modalities to actually manipulate or change orientation and attraction and to kind of cultivate heterosexuality in a person over time.
Now I know from her own video that when she's using the term conversion therapy, she's referring to all forms of counseling, and probably ministry, to assist people with unwanted SSA explore change in sexual thoughts, feelings, and behavior. So with all that said, this idea of conversion therapy being like a light switch, I don't know where she's getting this from. Nicolosi Sr. never taught that. He always gave a general synopsis of seeing 1/3 of clients experiencing no change, 1/3 experiencing significant change, and 1/3 experiencing complete change. Now I know this was kind of not an official statistic, it was more just a general synopsis of what he observed, so we take it with a grain of salt. Fortunately, we had the Pela Sutton studies show more detail, but we also have other evidence from other research. Nicolosi Jr. doesn't teach light switch idea. It's literally in our training materials that experiencing change in sexuality is not like a light switch, but more like a light dimmer. It's on a continuum.
So now I want us to be very clear. When we're discussing changes in sexual attractions, don't think in terms of flipping a light switch. Now, I know you know this, Andrew. I'm saying this more for other people watching, but don't think in terms of that. Think in terms of rotating a light dimmer. We're talking about gradual shifts of varying degrees. It's important that we don't oversimplify these results or overstate these results. Everyone responds differently. No one can guarantee an outcome. Even small shifts in attraction of a few degrees can help some individuals live in alignment with their values. Every individual has a unique journey, and these interventions might just be a smaller part of that individual's overall life journey.
And
So,
it's funny, if I
please.
could, I was just watching a recent video of someone criticizing the work we do, trying to actually assert that we teach the light switch kind of model.
Oh, yeah?
That so-called reparative therapy or reintegrative therapy or conversion therapy, they teach that you can just change your sexuality like a light switch when you should view it as a dimmer switch. I'm like, that's the opposite of what we say.
Maybe they were watching the video in reverse. Maybe there's like a YouTube option.
It's a core part of how we
Right.
explain things in all our teachings
Right.
and our videos. The continuum idea is how I've always understood it. This is what the Jones Yarhouse longitudinal study of Exodus member ministry participants showed. So if that's the case, where's she getting the light switch idea from? Show me. Bring the receipts, please. We've got decades of Exodus conferences, Restored Hope Network conferences, NARTH, and Alliance for Therapeutic Choice conferences, books by the leaders in ex-gay ministry, Joe Dallas, Andrew Comiskey, Ann Palk, now Ann Edward, Linda Seiler, Ken Williams, Stephen Black. I can go on and on. You won't find a quote from any of them claiming that change from homosexual feelings is something instantaneous. Now, what you will see are testimonies of people who lived in the gay life and that had a radical conversion experience and swore off their old life. And for some, repentance was instant and dramatic. Sure, why not? And there are some who have testified experiencing a relief from preoccupation with sexual temptation, usually immediately after their conversion experience. It's sort of like a period of grace that God gives to get them a taste of freedom. And He helps them with overcoming temptation more, or maybe make it so that temptation isn't as tempting during that period. But you won't see any of the major organizations, ministries, or counseling practices in our field promote this as the normal outcome or expectation. Because even when someone has such a radical experience so early on in their journey, the person still needs to follow through with discipleship and deeper inner healing. And this flash in the pan experience is something that we're concerned about. See my interview when I was doing a series of interviews with seasoned ex-gay people. In particular, I was discussing this with Michael Newman.
Joseph Nicolosi Sr.'s website states that, quote, he assisted over 1,000 clients in their goal to reduce same-sex attractions and explore their heterosexual potential. As a licensed clinical psychologist, he believed that our bodies tell us who we are, and that our bodies have made us for heterosexuality. Nicolosi Jr. and others who use reintegrative therapy emphatically state that it's distinct from conversion and reparative therapy in several ways, including attraction fluidity is a byproduct rather than the goal of therapy. At this point in my career, I can absolutely appreciate why Nicolosi Jr. would want to distance himself from the conversion therapy approach of his father. Many research studies document the harms of conversion therapy.
Is absolutely wrong. Proved.
We can glean barely anything from the studies like Shidlow and Schroeder or Blaznych et al. Because they're all retrospective and they don't distinguish between people who underwent professional therapy of any sort versus people who did a ministry approach or self-help approach. So this doesn't tell us much about the effectiveness of professional therapy for same-sex attraction, let alone Nicolosi's approach. We would need prospective studies to show causal links between a particular counseling approach and a particular outcome. And the first prospective study done on Nicolosi's approach was the Pela and Sutton study 2021, which she's going to completely botch in a bit.
And I've sat with many clients who share the ways conversion therapy metastasized shame and fear around their attractions that drove them into sexual acting out, isolation, and a lot of pain and self-guilt. Parents also come to my office and share about how conversion therapists told them that their child's sexual attraction was their fault, even though there's no research evidence to support this therapy. And for many people who went to conversion therapy, who talk about even positive or neutral aspects of their approach, they said that could have happened in any form of therapy.
But they didn't see just any therapist. What a thoughtless remark to make. So you're going to cast all the blame of clients' symptoms on reparative therapists or whoever else you deem a conversion therapist, but then you're just going to be dismissive of cases in which the therapy was helpful or at least neutral. I'm not getting the impression that you're engaging the subject in good faith.
So by the time Catholic families come to see me, they're eager to meet with a Catholic therapist who won't overpromise and underdeliver a therapeutic cure for homosexuality. They've already spent significant time and money on conversion therapy through individual sessions, family sessions, groups, and retreats, and have found it wanting. Many of these individuals still want to maintain their Catholic faith and live and value congruent ways, but find this super difficult in the aftermath of an approach that made heterosexual attraction synonymous with psychological healing and spiritual wholeness. The impacts of conversion therapy and the harm there I've seen time and time again, especially in people's doubts in God's love for them in the midst of enduring attraction to the same sex. In fact, many people I meet with feel no choice but to walk away from their faith altogether.
So she's going to cast all the blame for negative therapy experiences at the feet of Joseph Nicolosi Sr. This is outrageous. You cannot equate Nicolosi's reparative therapy with all counseling, self-help, or ministry approaches to addressing unwanted same-sex attraction. Reparative therapy was a very specific therapeutic approach. But, and mostly after Nicolosi Sr.'s death in 2017, activists and politicians increasingly used the term reparative therapy synonymously with conversion therapy. Not everyone in the conversion therapy umbrella was a reparative therapist. This is ludicrous and just plain defamatory. The Pentecostal pastor trying to cast out the demon of homosexuality is not a reparative therapist. The well-meaning guy running a support group at his church is not a reparative therapist. The redneck pastor running a boys' camp and beating kids with homosexual tendencies is not a reparative therapist. The 1950s psychologist using behaviorist approaches like aversive techniques was definitely not a reparative therapist. You can call all those conversion therapists all you want, but it's incredibly dishonest and misleading to call them reparative therapists or to equate Nicolosi's approach with them. And it's not a mystery what defines a reparative therapist. Nicolosi Sr. wrote books detailing what's involved in his therapy. I praise God he finished his revised edition of Shame and Attachment Loss before he passed away. It's the most thorough treatment of the latest iteration of his approach. So if you actually want to know what he did, read that book. What you have to understand about Nicolosi Sr. is he was devoted to helping people. He cared more about helping heal people than sticking to his presumptions. So he was always willing to grow and adapt his treatment approach to better fit his clients' needs. He started off very psychoanalytic, but he soon realized that his male clients with SSA needed a more relational approach. So he adapted, shifting from the blank screen approach of psychoanalysis to be more relationally engaging. And then he observed clients he described as the Teflon jellyfish, who are emotionally dissociated and having difficulty connecting with their feelings. So he developed 3-point bodywork to help people access their embodied emotions and gain insight and healing through double looping with the therapist and showing compassion to themselves. And he used that for many years to great effect. Then later in the 2010s, he began incorporating EMDR, eye movement desensitization and reprocessing, and using trauma reprocessing techniques to resolve memories beneath the arousal experiences. And this is all reflected in his book, Shame and Attachment Loss. So when Julia says she's worked with all these people who claimed conversion therapy caused fear and shame around their attractions, I highly doubt it was a result of Nicolosi's approach. His whole approach was about reducing shame, period. This whole section set me off, okay? When I first watched her video, there was, obviously, a lot that I wanted to say. But the first thing I wanted to do was speak up for Joseph Nicolosi Sr., who's not alive to defend himself. When I was persecuted in graduate school in 2015 for counseling men with unwanted same-sex attraction, one of the greatest encouragements that I received was a phone call from Dr. Nicolosi, one of my heroes. He bestowed on me the 2015 Joseph Nicolosi Student Excellence Award, and I had the immense honor of working on his research team until his untimely death in 2017 from the flu. And the comments I saw in news posts and on Facebook and just YouTube videos talking about his passing were horrendous, accusing him of torturing and killing children and gay men. I will always defend him, and I'm not blindly defending him either. He treated hundreds of men in California, one of the most left-wing states, and yet he never received a sustained mark against his license. So that tells me something, that accusations about him being torturing people are bogus. So I commented the following. When you conflate Nicolosi Sr.'s reparative therapy with conversion therapy, and then go on to assign aversive techniques to so-called conversion therapy, you accuse Nicolosi Sr. of aversive techniques. This was never true. And Julia was kind enough to reply. She said, "Thanks for watching the video. I tried to make it clear in the video that aversive techniques don't always go along with conversion therapy, and cite that some conversion therapists, like Nicolosi Sr., also state that they don't use aversive techniques. The point of that statement was to say that it's not fair to say reintegrative therapy is different from conversion therapy in that one always uses aversive techniques and the other doesn't, since some conversion therapists don't use aversive techniques. I do think reparative therapy falls in the category of conversion therapy, especially as conversion therapy is defined by Nicolosi Jr. Also, I have met with individuals who are clients of Nicolosi Sr. and shared about specific aversive techniques used in their work with him, despite him stating he never did aversive techniques, unquote. Honestly, I needed a day or two to think carefully, and then I replied, quote, "You say the point of that statement was to say that it's not fair to say reintegrative therapy is different from conversion therapy, in that one always uses aversive techniques and the other doesn't, since some conversion therapists don't use aversive techniques. But the chart on the Reintegrative Therapy Association website comparing reintegrative therapy to so-called conversion therapy says that conversion therapy only sometimes employs aversive techniques. And that's only because we're taking into consideration the whole history and global scope of approaches toward homosexuality. So the whole point you were trying to make was misguided. You want to be accurate, but you're going to use hearsay to substantiate your claim that Nicolosi Sr. employed or advocated for aversive techniques? The man wrote multiple books and articles teaching his approach. Give me a quote in any of his writings that advocate using aversion. You won't find it because he did not advocate using shaming, coercion, or pain in therapy. Those were all counterindicated by his very theory. It was Joseph Volpe, the originator of systematic desensitization, that proposed using aversive techniques to treat unwanted same-sex attraction, back when homosexuality was still classified as a mental illness in the DSM. That's a purely behavioral approach. Nicolosi, however, came from a psychoanalytic orientation. Behaviorist techniques were not his style. Furthermore, you ought to know as well as anyone that as soon as the term aversive technique is thrown out, especially in regards to therapy for same-sex attraction, the connotation in our zeitgeist is some form of torture, like electroshock or heating coils. You slander Dr. Nicolosi by associating him with such practices." Unquote. It's been weeks now, and she never replied to that rebuttal. This comes up in her interview with Gay X Trad when he asks her to define reparative therapy.
Which kind of gets us into the land of reparative and reintegrative therapy. Can you tell me a little bit about those backgrounds and how they say that they're distinct from conversion therapy?
Yes. So the reparative therapy model is really this idea specifically that same-sex attraction is caused by some type of developmental disruption or wound. And so there's an idea that if you can experience a kind of healing dynamic with a same-sex person, in this case a therapist, that it's going to repair those early childhood attachment wounds. And then at that point, you should see shifts in attraction over time. So some use of kind of aversive techniques, things like kind of mocking voice inflection in some cases, and other times, more of just a kind of therapeutic model that's focused on attachment healing. And so also a model that hasn't been shown to be effective over the course of research, but often again used as kind of a adjacent approach to conversion therapy.
Reparative therapy is Joseph Nicolosi Sr.'s specific therapy model. So to say that some techniques in reparative therapy involve aversive techniques, like mocking the client, you better have receipts. Show me where he outlines aversive techniques as recommended reparative therapy strategies in any of his books, articles, or lectures. I'm open to hearing it, but all I'm hearing from you is hearsay. If you can't do that, then this is just plain slander and spreading lies about his work.
So I was really curious when Nicolosi Jr. shared that he's really different from his father, Nicolosi Sr., in his ideas on homosexuality. So I wanted to understand the degree to which reintegrative therapy's approach would provide something altogether different from Nicolosi Sr.'s approach, after I'd witnessed the negative consequences of conversion therapy for over a decade.
When did Nicolosi Jr. say that he's really different from his father's ideas on homosexuality? When did he throw his own father under the bus? He hasn't. This is just an exaggeration of the significance of Nicolosi Jr. stating that reintegrative therapy is distinct from reparative therapy. He never disowned his dad, never said he's rejecting everything his father believed, nor should he have to. His father's beliefs and techniques stand on their own merits. But one distinctive with Nicolosi Jr. is he's not outright affirming all of his dad's views on homosexuality because he simply doesn't need to. Because reintegrative therapy intentionally aims to be theoretically neutral and more pragmatic. As clinicians, we look at sexuality in terms of attachment. So we use mindfulness and trauma reprocessing interventions to help strengthen a more secure attachment style. One of the things we always teach in our reintegrative therapy trainings is that reintegrative therapy is a methodology, not an ideology. If you follow the protocol, we suppose you can get the same outcomes whether the client or therapist are conservative, liberal, pro-gay, or pro-natural law. This actually is a distinction from Nicolosi Sr.'s approach, because Nicolosi Sr. typically advocated that the clinician needed to adhere to a natural law understanding of sexual normality. In reintegrative therapy, we don't say that's necessary, nor do we say it's necessary you reject it. Seems like she's just projecting her own ideas that Junior needs to fully reject Senior in order for his approach to be sufficiently different. That is an arbitrary standard.
We want to start with engaging with the claims of reintegrative therapy. Several questions arise as I've tried to learn more about the reintegrative therapy approach. A first question is this: to what extent is the theory behind reintegrative therapy similar or different to the theory behind conversion or reparative therapy? This matters because theory has everything to do with what makes one approach in therapy different from another approach. It has everything to do with the interventions we choose to adopt in therapy and has a great deal to do with the outcomes we'd expect at the end of treatment. For reintegrative therapy to be truly distinct from conversion therapy, I would expect its theory of development of same-sex attraction to be radically different from that of the conversion therapist. This goes for any established treatment.
Why? Why should you expect that? That's an arbitrary requirement. We can have the same theory for the development of same-sex attraction and two different strategies for how best to help someone resolve it.
If a person was offering an alternative to cognitive behavioral therapy, CBT, we would expect the theory behind the approach to differ in meaningful ways from a CBT approach. So when I look into the reintegrative therapy approach and listen to the video content put out by reintegrative therapists, especially the founder of the Reintegrative Therapy Association, I find the following theories of etiology, or the causes of same-sex attraction, as central to the reintegrative therapist's understanding of homosexuality, with a particular focus on male same-sex sexuality.
And she quickly cites Michael Gasparro's interview with Lila Rose as evidence. Did you watch that interview with an open mind, Julia? Because Michael is sharing from both his experience as a client and a therapist. And I'm friends with Michael. I've had him on my channel. I've been in plenty of clinical discussion group meetings with him. And one thing that always stands out about him to me is he is careful to be nuanced and respects the variance in our clientele. So even though he may have spoken of generalities we see in our clients regarding the contributing factors of our SSA in his interview with Lila Rose, he was careful to not be dogmatic.
So for the reintegrative therapist, same-sex attraction emerges because of at least one of the following experiences: early childhood attachment wounds, including having a distant father or a smothering or invasive mother, which reintegrative therapists would say leads to the developmental disruption in a young person's identity as a boy or a girl and their experience of the opposite sex. The theory follows that these attachment wounds will later manifest in sexualization of a person of the same sex and aversion to people of the opposite sex. Another possible causal path reintegrative therapists point to would be traumatic, unwanted sexual experiences or sexual abuse. Another would be traumatic early exposure to pornography, and yet another would be traumatic peer rejection. As far as I can tell, the theory behind reintegrative therapy is that of trauma of various kinds is going to cause same-sex sexuality to develop.
And where do you think we got those ideas? You think we just ponder them in a vacuum and force our clients into these boxes? These are the contributing factors that our clients identify, that they share with us or discover in the course of their work. And yes, they confirm Nicolosi Sr.'s predictions.
So for the conversion therapist Nicolosi Sr., homosexuality is an adaptation to trauma. It's rooted in a same-sex attraction problem, an attachment to a person's masculine nature. I see no distinction between the theory of homosexuality between a conversion therapist and a reintegrative therapist, which cautions me against accepting the claim that they're different in approach.
It really grates my nerves every time she calls Nicolosi Sr. a conversion therapist. Have a little respect and just call him what he was, a reparative therapist. Anyway, all her hand-wringing over this is overblown. First, in defense of Nicolosi Sr., he worked with over 8,000 clients. I haven't worked with that many, and I doubt she has. On top of that, he was trained in depth psychology, something that's sorely lacking these days. So he was deeply interested in characterological formation and transformation. Sadly, most grad school students are no longer trained in depth psychology, as the medical model prefers short-term therapy. He wasn't some CBT therapist that doesn't care about the client's past and their development. He was adept at helping clients connect present emotions, thoughts, and behaviors with past experiences. So, when you take that type of therapeutic approach and see that many clients over years, you're going to pay attention to trends in your cases. He didn't just make his ideas up a priori. They developed after years of hearing men's stories. And so yes, he put his conclusions out there quite confidently. He had the experience and expertise to back it up. Now, could he have been a bit more nuanced in some of his public statements? Yes. I've always believed that he didn't point out the exceptions to the generalities he saw with his clients enough. But if you actually read his books, you would see that he was well aware of the variations in presentations of men with same-sex attraction. His primary focus was on the men whose root issues stretched back to the earliest stages of development, because that's the majority of cases, what he would call the pre-Oedipal type or pre-gender identity stage development type of same-sex attraction. But he also recognized that there were several subtypes of homosexuality, outlined on page 71 in Shame and Attachment Loss. And I would agree that the way he would use the word trauma in public presentations could evoke ideas in people's minds that what he's suggesting is limited to violence and abuse. But he didn't always mean that. Instead, he understood trauma as an experience that significantly altered the course of normative development. So yes, attachment loss, peer rejection, pornography exposure, given a particular temperament in the child, can all be traumatic. This shouldn't be so scandalous. I certainly believe there were plenty of people who had a passing familiarity with Nicolosi's theories. Before I ever read Shame and Attachment Loss, and before I ever met Nicolosi and trained under him, I had heard elements of his developmental model for explaining male homosexuality. What I heard, I agreed with because it fit what I observed in the men in the support group that I was running and what I observed in the people I knew with SSA. But I had enough wisdom to know that I was not sufficiently trained in his approach to call myself a reparative therapist. So for years, I operated closer to a sexual identity therapist, a la Yarhouse and Throckmorton, assisting men with living congruently with their faith, despite any persisting sexual attractions. But all the while, I was eager to finally learn strategies for actually helping people with the emotional element, not just the cognitive and behavioral. Anyway, I don't think everyone had that type of discretion. So a lot of therapists or just lay counselors would encounter an abbreviated presentation of Nicolosi's theory and then try to apply it in rather presumptuous ways. I believe a lot of people had some degree of familiarity with Nicolosi's developmental model, but they weren't trained in his actual therapy, like body work, double looping, and trauma reprocessing. They get a hold of an explanation for someone's SSA and then think they just need to communicate it to the client, hoping that some epiphany alone will do the trick, or trying to use their own modality for the treatment approach. But this obviously could lead to a lot of non-standard applications of his theory. Julia, I don't know how familiar you are with Nicolosi's actual theory and application of his theory, because I know there's been a lot of people who would just quickly dismiss what he said until they actually read his books. I saw this in Beckett Cook, who, when I read his book, Change of Affection, he had like a very passive dismissal toward Nicolosi's model, because he only heard, like I said, an abbreviated version of it. And I prayed that he would actually do a little more digging, and he has, because he recently had Nicolosi Jr. on to talk about his father's book. And as he actually read Shame and Attachment Loss for himself, he was having all these epiphanies and seeing the connections. Things that I was able to notice when I read Beckett Cook's own autobiography. I'm like, well, he fits actually a lot of what Nicolosi Sr. is saying. He just doesn't seem to be aware of it. And so it was actually confirming much when Beckett Cook was making these connections on his own, reading Shame and Attachment Loss. I see this with my clients all the time. And when they start reading it, they're like, oh my gosh, it's like he knows so much about me. Well, that's because he's been working with hundreds, or he had been working with hundreds of clients over many years. He was very familiar with the trends in clients with same-sex attraction. So many clients, I can't tell you, so many clients who, when they actually read Nicolosi Sr.'s books, they're astounded how much they can relate to it. They're not just going off some straw man of it out there, or some truncated presentation, whether it's presented positively or negatively, because even a positive presentation of his model leaves out a lot of the nuance. So when they actually read it, they see all the nuance that he actually was aware of. They realize, oh wow, he really does get me. But the problem is, I think a lot of people just had a very small idea of what his, not just his theory of what causes same-sex attraction, but also how best to then help them, individuals who are looking for assistance with developing their heterosexual potential or reducing same-sex attraction. They just thought they just need to present the theory, the model of what caused their attractions, and that'll be enough. Or they would just try to force it on people and help them to see something and have an epiphany. So I think there could have been some harm done by people who weren't actually trained in authentic reparative therapy. So with reintegrative therapy, we want to prevent such a top-down approach of imposing a theory on clients, which can pose risks to the client and treatment, like causing strife between a client and parents, like exasperating an obsession over finding the root trauma, depression over not fitting the classic cases, so believing there's no hope for oneself. We're aware of those risks. So this is one of the reintegrative therapy distinctives Julia Sadusky doesn't seem to get. Whether or not Nicolosi Jr. or any other reintegrative therapist continues to agree with Nicolosi Sr.'s developmental model is mostly irrelevant, because the reintegrative therapy protocol is intentionally designed to be bottom-up. We don't just give clients a theory about why they have SSA. No, we train our clients to develop a curious, mindful approach to their attractions and behavior, which facilitates the clients discovering their own nuanced and unique stories. Do our clients continue to fit what Nicolosi Sr. had long ago observed? Typically, yes. But not because we're forcing our clients to fit any such theory. And we fully recognize that client stories vary, and there are exceptions to every generality, which Nicolosi Sr. also recognized. But also, beyond just creating an approach that helps clients discover their root issues on their own, the reintegrative protocol is designed to heal the underlying trauma and emotional learning. Clients come away with a new implicit knowing, a knowing that doesn't come just from someone telling you something, but a knowing that comes from the lived experience of a shift in one's arousal template. So that leads us to the next area of contention, the results.
So if the theory behind these approaches is almost identical, you may be wondering, what is different between these approaches? For starters, reintegrative therapists say that their approach is different in that the goal is healing of trauma, not attraction change per se. We'll circle back to this point later more fully when we look at what reintegrative therapists are measuring as outcomes of successful therapy. Yet another reported difference is that whereas conversion therapists used aversion techniques, which are any efforts to lead somebody to associate disgust, pain, or displeasure with a behavior, a thought, or an emotion, reintegrative therapists report that their approach avoids these aversive techniques. I am grateful to hear that reintegrative therapy avoids aversion techniques, which have not been effective long-term for behavioral changes and have often taken forms that are outright harmful and deeply concerning. I've met with many clients who sought out conversion therapy that incorporated these aversion techniques, things like mocking their own voice inflection, their mannerisms, or their interests, in an effort to somehow reduce gender nonconformity, as if that would somehow increase connectedness to masculinity or femininity. It's difficult to fully appreciate the harm of these interventions on a person's sense of self and mental health until you sit across from somebody who's endured them. It is important to note that aversion approaches are not synonymous with conversion therapy, and plenty of conversion therapists sometimes also report that they don't use aversion techniques. I've also met with countless clients who sought conversion therapy and never experienced some of these aversion techniques, but were actually offered trauma-related interventions of various kinds. This renders the distinction made by reintegrative therapists actually less meaningful than we might originally think.
But it still needs to be said, because unless you've had your head in the sand for the past 20 years, you would know that the LGBT activists have done an effective job of convincing the public to associate therapy for unwanted same-sex attraction with torture. Boy Erased featured a scene of a boy being hit with Bibles, an act that wasn't even in the memoir upon which the movie was based. I distinctly remember getting into a flurry of online arguments with people in the comments section when Joe Nicolosi Sr. died, because one person after another was saying, "Good, he won't torture any more kids." So yes, as long as the pairing of conversion therapy and torture persists in the world's collective psyche, we need to make clear that reintegrative therapy does not use aversive techniques.
The Reintegrative Therapy Association site also indicates that the approach is simply using trauma-based interventions, again, trying to distinguish itself from conversion therapy. And when I looked at the published paper on this approach, it appears that at least some of the interventions are evidence-based trauma interventions, such as using EMDR and self-compassion in therapy. So this raises the question, why do you need an altogether different, trademarked approach? Why not simply be a trauma therapist offering evidence-based trauma therapy to treat trauma symptoms when those are present? If the goal is trauma treatment, not change of attractions and orientation, I struggle to understand the need for a new, trademarked approach that measures change of attractions rather than trauma symptoms at the end of therapy.
Why? First off, because clients have every reason to not trust clinicians in the area of sexuality. The sexual orientation paradigm is so pervasive in our field, even among so-called Christian counselors, that therapists have a major block when it comes to sexuality. They check all their clinical training and intuition at the door when it comes to sexual attraction issues. I've had plenty of clients who had seen other therapists prior to me and they just hit a wall because the therapist bought into the presupposition that if you have same-sex attractions, then you're gay, meaning you have an innate and immutable homosexual orientation. So, they would avoid using their clinical training if it involved reprocessing experiences that could affect their sexual attractions. This was the case when I got sacked at a so-called inclusive Catholic university in graduate school, Chestnut Hill College in Philadelphia back in 2015. They accused me of doing unethical practices just because I was using my clinical training in trauma and addictions to assist men with unwanted same-sex attraction during my internship. I wasn't doing something bizarre. I wasn't doing anything outside of the actual training I was receiving. They just didn't like the therapeutic goal that the clients had. And so the approach I was using was discouraged, not because I was doing anything actually harmful. So this is what clients come across, or come up against, when they see just a therapist who just happens to be a trauma therapist. As soon as they see it, oh, they're trying to use this to help work on their same-sex attractions, they say no. They put the kibosh on that. Heck, even some of the EMDR associations condemn using EMDR to help clients with sexuality conflicts. Secondly, because in the reintegrative protocol, we don't start with the client's early trauma, but with the client's unwanted sexual attraction, fantasy, or behavior. We don't presume a trauma. The protocol facilitates the client floating back and discovering on their own the experience at the root. Then we use a memory reconsolidation intervention. Upon completion of the reprocessing, we go back to the initial sexual experience and reassess the client's feelings about it. This is a protocol that your typical trauma therapist would not know to do, especially when it comes to sexuality. Indoctrinated in the sexual orientation paradigm, they're not trained to be curious about the meaning of the client's attractions. Some may have started the therapy attempting to be neutral, but when push came to shove, they showed that their true colors are LGBT affirmative, as they got exasperated with the client who was bothered by their same-sex attractions, exclaiming eventually, "You just need to accept that you're gay." I've had clients come to me who had previously seen regular therapists, and they would start off neutral, but eventually they would say that to the client, getting frustrated with them, or trying to be like, all right, I got to give you a reality check. I just got to give you a hard truth here. You're just gay, and you need to accept that. Okay, that's what you get from non-reintegrative therapists or non-safety therapists in the world. Heck, your typical trauma-informed therapist these days is going to presume that the only trauma the client may have is the experience of homophobia and stigma about their sexual orientation, which may be true. And the first step with a lot of my clients is helping them to get to a state of mindfulness and self-regulation regarding their conflict. So I'm not denying the impact of shame and taking a moralistic approach to SSA. Just watch my videos. I'm very vocal against the mortification stream, or side Y. But gay affirmative or side B counselors don't have any curiosity about the life experiences, trauma or otherwise, that may be at the root of someone's SSA. They just assume it's an innate trait they must embrace as part of who they are. So yes, we need a therapeutic approach that utilizes the latest innovations in trauma reprocessing and memory reconsolidation and trains clients in curiosity and mindfulness in order to help people with any sexuality conflict. Because reintegrative therapy is used not just for same-sex attraction, hence why that's another reason why we don't want it to be lumped together with conversion therapy. But reintegrative therapy can be used for any sort of sexual conflict, whether it's heterosexual sexual addiction issues, unwanted same-sex attraction and homosexual behavior, fetishes. We use it for a wide range of things because we are training our clients to be curious about the meaning of their sexual fantasies and feelings.
And as a Catholic, I'm aware of no official magisterial document that claims trauma is the cause of same-sex sexuality. I also see no indicator in church teaching that the Catholic who experiences same-sex sexuality ought to seek trauma therapy and expect change of attractions or orientation in order to be faithful to Christ.
What a bunch of strawmanning. Whoever said you have to do all of this in order to be faithful to Christ? No one is arguing that you must change your sexual arousal templates in order to be a good Catholic or Christian. Yes, you can choose to bear with it for your whole existence, and there is nobility in that. But one of the virtues promoted in Catholicism, and ought to be promoted in Christianity in general, is magnanimity, which is greatness of mind and soul, the pursuit of the more that God has for you. So it's not that you have to change, but you get to change. So unless you're pro-LGBT, why would any Christian counselor discourage any clients from having such an open attitude? Furthermore, chastity is about more than mere abstinence from sexual sin, but it entails the right ordering of one's desires. See my video series on Pope John Paul II's book, Love and Responsibility, for more on this, especially the part on how it all applies to homosexuality.
In fact, the available documents related to same-sex sexuality indicate, in quote, there is currently no scientific consensus on the cause of the homosexual inclination, end quote, and make it clear that there's also no consensus on the helpfulness of therapy to change attractions. This is in keeping with the current science, where there continues to be no consensus on the theories of causation, contrary to what reintegrative and conversion therapists alike confidently claim.
Of course there's no consensus on the causation of same-sex attraction among the professional organizations. Surely you're not so ignorant that you're unaware of the overt pro-LGBT bias in the field of psychiatry and psychology. When the APA made their 1973 decision to declassify homosexuality as a disorder, there was not consensus, especially among the psychoanalysts who understood it as a form of arrested development. But the organizations have been ideologically captured and actively silencing dissent for decades now. Lately, one of the main tactics is to retract any journal article that presents evidence that contradicts the sexual orientation and anti-conversion therapy narrative. Pursuit of scientific inquiry is not encouraged these days. But lack of consensus, especially among secular ideologues, should not limit us from proposing theories based on trends we observe in our clients and in research.
So are the theories of the development of homosexuality different enough between conversion and reintegrative therapists to indicate them as distinct therapies? It's clear that Joseph Nicolosi Sr, the founder of Reparative Therapy, believed the very same thing about same-sex sexuality that his son, the developer of Reintegrative Therapy, also believes. Both claim that same-sex sexuality is caused by attachment trauma and other forms of trauma that disrupt developmental processes, despite no scientific consensus or scientific basis for this theory.
Again, if you want to say there's no scientific consensus, fine. But no scientific basis? Give me a break. Do the research.
You've got to do better.
Again, why would you, a Christian counselor, discourage a sexuality struggler from being curious about the development of his or her sexual feelings? It's funny, you scoff at the idea that attachment loss could be the root of same-sex attraction. And yet on your website, one of your recommended resources is the Adam Young podcast. Now, I don't know where Adam Young stands on homosexuality, but I know that he's a big advocate of understanding sexuality in light of attachment. So, assuming you can agree with that theory, why would you not see it as reasonable that same-sex attraction, an attraction that clearly contradicts God's design, what your own church calls an intrinsically disordered desire, would be rooted in attachment wounds? It's ironic. She acts incredulous over the idea that parenting impacts sexuality, but two of her recommended resources are books on dealing with emotionally immature parents. So parenting and attachment can impact personality and psychology, but just not sexuality? And again, we don't assert or presume attachment wounds or trauma. The client makes his or her own discoveries through our bottom-up protocol. We observe attachment wounds as a common root issue. Though, like I've said, we observe multiple potential roots. And this finding is consistent with what we would predict from a Christian anthropology. See my video on a sexual arousal templates for more on that.
This calls into question any meaningful distinction between reintegrative therapy and conversion therapy, as their theories are really the same. Whatever differences exist between these two forms of treatment are much less relevant than the driving theories that anchor their shared approach.
Yeah, the differences between reparative therapy and reintegrative therapy are very minimal. So what? You're begging the question when you presume that being similar to reparative therapy automatically discredits reintegrative therapy. For the record, here are the nominal differences between the two. First, reparative therapy was originally very psychoanalytic, but like I said earlier, Nicolosi Sr. was always willing to adapt and innovate, so it went through a few transformations, becoming increasingly more trauma-based. That alone is sufficient to justify a new name. Secondly, reparative therapy was designed specifically for homosexuality, specifically male homosexuality. Reintegrative therapy, though, is actually much broader, serving as an approach for trauma and addictions in general, though of course it's particularly useful for sexual attraction fluidity exploration. But I use the same reintegrative therapy interventions for clients with any sexuality conflict, same-sex attraction, heterosexual sex or porn addiction, and all sorts of sexual fetishes. But it can also be used for any sort of compulsive issue, such as binge eating disorder. In fact, the first study published on reintegrative therapy was a pilot study of its use in treating binge eating. So we want to make it clear that this is not a novel therapy or a bizarre, exotic therapy used just for this one particular issue. But it's an approach using evidence-based treatment protocols that can be used to great effect for those with sexual struggles and compulsive issues. Thirdly, one of the other distinctives is reintegrative therapy is much more protocol-based, and maybe most importantly, it's standardized and well-regulated. Whereas a lot of people claim to be reparative therapists despite lacking sufficient training in Nicolosi's actual approach, like I was saying earlier, you cannot call yourself a reintegrative therapist without training by the Reintegrative Therapy Association and completing the necessary supervised client hours to gain certification. This is to ensure that clients receive the most professional and ethical care. To that end, another distinctive is we're careful in reintegrative therapy to utilize well-regarded assessment tools for a variety of relevant conditions in order to make sure our treatment is research and data-driven.
Is it accurate to assume that same-sex sexuality is a symptom of trauma?
No, it's not accurate to assume same-sex sexuality is a symptom of trauma. Good thing we don't do that. We don't assume anything. I'll have clients beg me to just tell them why they have their attractions. I won't. I tell them to trust the process, to be curious and open, but not obsessed with finding the root. I may even refrain from doing the protocol with them until they're in a state of acceptance of their experience. We especially have to take this approach with our many clients with OCD tendencies. So no, we don't assume trauma. Clients discover underlying wounds as they engage with mindfulness, curiosity, and self-compassion. But now she's going to just go and strawman us. It's really reprehensible.
One mistake that the reintegrative therapist makes, that the conversion therapist also makes, is that they both assume trauma symptoms are present with every client who experiences same-sex desire, in line with their theory of homosexuality, rather than assessing for and documenting trauma symptoms that ought to be addressed with trauma interventions. To assume that same-sex sexual desire is itself a trauma symptom is just that, an assumption. It may seem logical to some of us, but that doesn't mean it's an accurate assumption. As a trauma therapist who often works with survivors of complex trauma, I would caution any therapist against assuming trauma symptoms when they aren't present and being reported by the client. Every therapist runs the risk of making assumptions, especially when we work in a particular area of specialty. Our biases can lead us to see trauma where it isn't, just as a therapist who often works with people with bipolar illness or autism might be prone to overdiagnosing it. Too often I've heard from individuals individuals who have sought reintegrative therapy and conversion therapy and have been told that they have trauma histories, even when they consistently tell the therapist that they don't. The exhaustion of being on a wild goose chase to find the trauma is hard to appreciate until you've lived it.
See, I don't know if you're talking about people who've seen reintegrative therapists, of which there are very few, or who've seen any of the so-called conversion therapists you've lumped us in with. But like I've been saying this whole time, the reintegrative therapy protocol is particularly designed to avoid imposing a theory or model on the client. So I'm going to be very skeptical of this claim she's making here.
I've also sat with people who were put through EMDR protocols by reintegrative therapists without being told that EMDR is a trauma treatment and without themselves having a history of trauma. These individuals only discovered the fact that they were being treated for a trauma disorder they were never assessed for when I told them that EMDR is actually a trauma treatment.
This is one of her most ridiculous charges in her whole video. A client doesn't need to have a trauma or PTSD diagnosis to benefit from EMDR. She's misleading her clients by presenting EMDR in this way to them, making something routine sound scandalous. This was so outrageous, I had to bring it up in my recent interview with Joe Nicolosi Jr. One of the things that might stand out to people is we're using, say, interventions that are common to use in trauma reprocessing, trauma interventions, but yet we don't require the person have a traumatic memory for us to do this, because we're just targeting, when we're doing this particular intervention. Some of our other interventions within reintegrative therapy are more trauma focused in that we're going to a painful memory.
Yes.
But with these particular interventions that we're doing in this study, it was just go to a memory that has arousal associated with it that you don't want. And that may be a traumatic experience, like say there's a sexual abuse memory where there's both pain and fear associated as well as arousal, or it could just be something that's purely arousing for the person.
Right.
So one thing that might stand out to people, oh wait, you're using trauma reprocessing for something that's not trauma. So does someone need to have a diagnosis of PTSD in order to do an intervention that is also used in trauma reprocessing?
Does a person need to be diagnosed with major depressive disorder in order to get treatment to reduce depressive feelings? Does a person need to have generalized anxiety disorder in order to come into session? I'm really anxious about something, and we work on. What does the therapist say? No, you don't have a diagnosis, so I'm not going to help you lower anxiety. So that makes no sense when you extrapolate out to any other clinical phenomena. The second thing is, these interventions are used for a variety of them. EMDR, for example, is used for, it's a trauma treatment, but it's also been shown to be effective for, for phantom limb syndrome, anxiety, eating disorder, a variety of different things. So no, you don't have to have a diagnosis to get an intervention.
Speaking of, I remember back in graduate school, in my trauma intervention class, when my professor brought up EMDR, said that she knew of a case where someone had a fetish. I forget what type, it might have been a foot fetish. And they traced it back to what that foot fetish was related to. It was like an attachment to a babysitter. And used EMDR on that, and the foot fetish disappeared. Incredible. So I knew about this going back, I don't know, 2013. So it's been out there. The client didn't need to have a trauma to still benefit from the EMDR.
There's no rule. There's no rule that states that.
This begs the question of informed consent and client autonomy versus a therapist's assumptions driving treatment. From a trauma-informed perspective, pushing, even subtly, a theory on a client who doesn't believe they have a trauma history is at best disrespectful and at worst coercive.
Now she's just getting downright inflammatory, accusing us of being disrespectful and coercive of clients, insinuating that we're not providing informed consent. She's not privy to our informed consent documents and process. It's all hearsay. And if you go to any of our trainings or our videos, we make it very clear the client determines their therapy goals. We don't impose anything on the clients. We don't coerce them. We're going to get into the Pela Sutton study in a moment. Well, for that large-scale longitudinal study of men with SSA, the inclusion criteria was quite clear. Do you have SSA, and are you willing to do a trauma-based therapy? For the one study involving clients doing reintegrative therapy, the clients were informed about the interventions being utilized. So this claim that clients weren't aware that they would be doing trauma interventions like EMDR is spurious. It's one thing if you're going to address isolated cases of therapists violating ethics codes, but this video is addressing reintegrative therapy as a whole. If there happen to be certified reintegrative therapists out there not following ethical standards, by all means, go through the proper channels to resolve that, which she hasn't done. But what she's doing in this video is taking situations based in hearsay of therapists who are purportedly reintegrative therapists, allegedly practicing unethically, and then using that to characterize all of reintegrative therapy, and thus justify her position that reintegrative therapy should be marked and avoided. That is unethical on her part, because you won't find anything outlining the standard practice of reintegrative therapy, whether in our training materials or in the journal articles detailing our practices, that involves tricking, coercing, or forcing clients to do trauma interventions against their will. What she's saying here is downright slander.
Expecting a client to address trauma without the client's willingness or awareness is not trauma-informed, but actually runs the risk of enacting trauma dynamics, power and coercion in therapy. Surely, as a trauma therapist, I've met with people who report trauma symptoms, things like flashbacks, intrusive thoughts, emotional and thought disruptions that came from trauma, but really struggle to name or talk about their experiences as traumatic. And of course, I would love to help them come to a place of freedom in acknowledging and addressing these symptoms. But I recognize the damage in beginning to treat their trauma without their consent or understanding of this reality in their life. This becomes especially problematic if, rather than measuring or observing objective trauma symptoms at the start and end of therapy, a therapist were to assume trauma is present based on their own personal theory about how same-sex sexuality comes to be. And even when a client who experiences same-sex sexuality has a history of trauma, there is no research base to support the claim that trauma causes their same-sex desires, or that addressing their trauma will make their attraction change.
This is incredibly aggravating. It's just one falsehood after another. And now she's going to put her own lack of credibility on full display as she tries to critique the research on reintegrative therapy, particularly the Pela and Sutton study from 2021.
The next question worth asking as we explore reintegrative therapy is this: is there significant research evidence to demonstrate that reintegrative therapy does what it says it does? Anytime I'm looking into a new treatment approach to consider incorporating in my practice, I look at the research base. I wouldn't say reviewing research is the highlight of being a psychologist, but it's a necessary part of ensuring the therapies that I offer are grounded in something beyond my own interest in them or a personal or cultural perception of their efficacy. So when I look at the Reintegrative Therapy website's research, it states that it has large-scale, longitudinal evidence that reintegrative therapy, and I quote, is associated with statistically significant decreases in same-sex attractions, increases in heterosexual attractions, changes in sexual identity toward a heterosexual identity, and increases in psychological well-being, including decreases in anxiety, depression, and suicidality. To any reader, this statement likely sounds astounding, promising, and intriguing. Words like large scale and longitudinal evidence pique our attention, even if we aren't familiar with research jargon. Many people seeking out this approach are desperate to find a way to get rid of their same-sex attraction and will do whatever it takes if told there's strong evidence their attractions can change.
In the interview with Gay X Trad, she makes her own views most clear, that people might have some small degree of natural sexual attraction fluidity, but she doesn't believe any sort of intervention can actually boost their fluidity. It seems she's letting her own biases and presuppositions cloud her awareness and understanding of existing research that shows that interventions like trauma reprocessing, memory reconsolidation, and mindfulness can have spontaneous, even non-voluntary effects on sexual attraction, even without the participants trying for it.
And in your experience as a licensed clinical psychologist working with clients, the reintegrative, reparative, conversion therapy, that whole mess, does any of it actually work?
So what I would say about that is we have well documented in psychology that there's something called sexual fluidity. So Lisa Diamond, secular researcher, kind of like really the head of looking at sexual fluidity, found, especially in female clients and people who were researched over many years, that women more often will report a kind of fluidity, an ebb and flow in attraction over time. Now, the key to this is it's natural fluidity. It's not fluidity through intervention. There's kind of a natural ebb and flow in attraction, maybe how people identify, sexual behavior, sexual expression can ebb and flow for people over time. And so that's well documented, okay? So about, if you look at studies that looked at, kind of changes, shifts in attraction over time, for some people, you will see some shifts in attraction over time. Maybe a person who experienced, bisexual attraction might experience an increase in opposite sex attraction. They have the capacity to be in a romantic encounter with somebody of the opposite sex. That can happen sometimes. People share about that. The question becomes, is that natural fluidity, or is that something that's being cultivated through a therapeutic modality? And we can't even say through a therapeutic modality and research in that there's a causal shift from the therapy. We just don't have the capacity in research to be that precise. And so I think it's fair to say that there are people who will experience shifts in attraction over time. One longitudinal study done by Mark Yarhouse and his research team found in ministry groups, so not therapy, but ministry groups, about 30% of people reported some level of shift in attraction over time, but we're talking 70% of people who didn't.
Now, I have a little correction there with some text, but for those who are just listening to this podcast, it would be helpful to hear this as well. That Jones and Yarhouse longitudinal study of participants in different Exodus member ministries actually shows 23% experience what they would consider complete change, which I imagine there's still some degree of SSA that might come up at times. 30% experience significant change, where it's very manageable and not as pressing an issue. 16% experienced minimal change, but they were still committed to the process and they're going to continue doing their work. And then the rest was no change. So this idea that only 30% experience change, it's not what the study actually showed.
And so the idea that most or all or even many people experience meaningful shifts in attraction through therapy or ministry would be an overstatement at best.
She completely ignores the Pela Sutton study. We are well aware of natural, non-therapeutically mediated sexual attraction fluidity, but that cannot explain the shifts reported in the Pela Sutton and other studies. See these clips from my recent interview with Nicolosi about the research on using memory reconsolidation interventions and experiencing sexual attraction changes.
That's what I want to do. So I searched the research literature for studies examining sexual attraction changes as a spontaneous byproduct of interventions that do not attempt to alter anyone's sexuality. I specifically selected sexual orientation neutral interventions, as described earlier. So here's what I found. I found 6 research studies from 3 continents, authored by both pro-LGBT and traditional conservative researchers. So it's very diverse. I'm going to show them to you, see if you notice any patterns. An Australian study with 28 participants used bilateral eye movements while recalling sexually arousing fantasies. Their arousal quickly decreased and remained lower at follow-up. A controlled study from 2 universities in the UK examined 40 participants who performed bilateral eye movements while thinking about their sexual fantasies and memories. Their arousal also decreased. In the US, a case study followed a single participant, and that's what case studies do. They find one person and they do a very in-depth analysis. So a case study followed a single participant who received EMDR which also incorporates bilateral eye movements to address trauma. Over the course of treatment, the individual's sexual attraction shifted from predominantly homosexual to predominantly heterosexual. A study in the US examined 29 women who identified as heterosexual but had homosexual and heterosexual attractions. They practiced mindfulness meditation and reported decreases in their homosexual attractions and increases in their heterosexual attractions, results which were further reinforced by brain scans of those participants. Then we have my research study. Excluding the participants who received a placebo, we end up with 108 participants who received an intervention. That decreased their unwanted sexually arousing memories in just 8 minutes. And the effects were shown to be durable because of the follow-up assessments. The Pela and Sutton study on reintegrative protocol involved 75 participants. They reported decreases in same-sex attraction experiences, increases in heterosexual attraction experiences, improved psychological well-being, and reduced psychological distress. So, in summary, across 6 studies spanning multiple continents and involving researchers with different ideologies and backgrounds, there were 281 documented cases of spontaneous sexual attraction changes. So that is the rebuttal to the inefficacy argument, that change is impossible. There's no link to there's no study has any evidence that anything could be changed by an intervention. That's the response to that. Now let's turn our attention to the third argument, the harm argument. The total number of adverse effects, are you ready for this? The total number of adverse effects reported by the 281 participants was 0. This is a critical response to the harm argument. 0 from 6 studies and 3 continents, okay? So over the past few years, growing, and you can see these studies are pretty recent, relatively recent. In the research world, this stuff is considered recent. So growing global research suggests that interventions triggering spontaneous attraction changes are not only effective and harmless, but might actually demonstrate evidence of psychological benefit.
So another thing I want to point out with this one, well, a few things. I've noticed any patterns. One pattern I would say is the first 4 studies you bring up, very small sample sizes. And also very recent studies. And so that should do one thing for us as people who actually care about the science and research is, we should do more research. And that tells us that the claims that the critics of change-oriented therapies that they're levying are premature. They're saying that therapies out there for exploring change in your sexuality are ineffective or harmful, when we barely had any research to justify that sort of claim. So there's small studies that we even had, and there are recent studies. But people have been making these accusations against us for years prior to these studies ever coming out. The other thought is, because I'm very familiar with the Pela and Sutton study, is the p-value of those studies.
Yeah.
The intervention showed 0.0001, which means that whatever change they experienced in their sexuality could not have been from outside experiences, but from the actual interventions that they were experiencing in the therapy. That it's highly unlikely that it would be something else.
Right.
So people need to keep that in mind. That's a major point that stood out to me from the Pela and Sutton study. That it was not, because people say, well, Lisa Diamond's research shows that people can have sexual fluidity without any interventions, and so we don't know if these interventions that they're doing were what actually changed their sexuality.
Right.
The p-value shows otherwise.
The p-value shows otherwise. The p-value of 0.0001. That's saying that there is less than a 1 in 1,000 chance that this is random chance. So yeah, that's very important.
So let's dig into these terms. Large scale, as defined by the social sciences, refers to extensive research programs and networks that bring together researchers from diverse backgrounds to address common global issues requiring significant human and financial resources for interdisciplinary and international collaboration.
Large scale can also just mean that the sample size was large enough to be potentially generalizable. And that's what it means in this case. 75 participants in a study of a niche population is large scale. This criticism just reeks of desperation on her part. The study was conducted at more than one clinical site with 5 therapists and included clients from the U.S. and abroad who came to the U.S. to take part in the therapy. This counts as large scale.
So we would typically expect a large-scale study to at least have hundreds of participants. Longitudinal evidence means that the participants in a study are followed over a sustained period of time. This is meant to help us demonstrate sustained shifts rather than natural shifts that return to an original baseline or would have recurred regardless of intervention. Having a longitudinal study where a majority of the participants stay in the study is actually what gives credence to the conclusions we draw about the effects of a therapeutic intervention. The single study, Pela Sutton, 2021, that's cited to support reintegrative therapy began with 75 participants, which is a non-negligible number, but it's nowhere near what we would need to qualify a study large scale. Less clear from the summary statement on the website, only 22 participants remained in the study for the 2 years they were being followed. This is an incredibly low retention rate of 29%, which severely limits what can be said conclusively with the available data.
Here we go. She completely misrepresents the research design and outcome data of the Pela Sutton study. She's using the same arguments Gregory Coles tried to use in his essays criticizing the same study a couple years ago.
According to the abstract, this 2-year longitudinal study featured 75 adult male participants. In reading the study itself, we learn that this is true, but not the whole truth. In fact, 105 adult males began the study. By the end of 2 years, only 22 of them remained. In other words, the study was truly a longitudinal 2-year study, and it did in fact have 75 participants, but only 22 of those participants were actually studied for the full 2 years. The other 53 discontinued therapy before then. This places the study's retention rate at a striking low 29%.
Well, Julia, you copied off the wrong kid in class. I already thoroughly dismantled Gregory Coles in this video. Not to mention I interviewed Carolyn Pela and Joe Nicolosi Jr. after the study was originally published. So you can hear from Dr. Pela herself as she explains the research design.
So Dr. Pela's work is really kind of a different category of work. It's people who are open to exploring it and just seeing what happens when they receive trauma treatment.
Here's something else that's really different about this. We were flies on the wall. So this isn't like your normal laboratory study. We were just coming in and observing what's happening to real people in these real clinics, everyday life, which again, the validity and the generalizability of our findings is increased because of that part of the design. So I just wanted to throw that in there because these folks were people who were just going to therapy. We didn't require a certain number of sessions. Their therapy just went as their therapy went, and we
So it's
just
a very natural
observed.
process.
Exactly.
The fact these falsehoods about the study are still being promulgated to this day is appalling. Julia, you should be ashamed of yourself for everything you've said in this video, but especially this part. You are misrepresenting the research to the public, and that is a serious ethical violation. She falsely claims that the Pela Sutton study followed only 22 participants and that most of these 75 participants did not stay in the study, trying to conclude that we have no way of knowing the outcome of 71% of participants. That is incorrect. All 75 participants met the pre-established inclusion criteria of staying in the study for at least 6 months. So you have the baseline assessments and a 6-month assessment. The outcome data reflect complete reports from all 75 participants. Many participants identified as dropped out by Sadusky and Gregory Coles were actually early completers who met their therapy goals before the 2-year maximum follow-up period. Okay, all they had to do was agree to do the therapy. They do assessments at baseline and then another assessment every 6 months. There's no requirement that they stay in the whole study of 2 years. It wasn't a 2-year study. It was a longitudinal study in that they would be assessed every 6 months during their therapy up until 2 years, because she had to set a limit at some point, Carolyn Pela, and actually publish her findings. So she couldn't just keep doing assessments indefinitely or doing assessments post-therapy, because that can impact the actual outcome data and the effectiveness, or the report on how effective therapy was, because they could then have confounding factors after the discharge. So it was only while they're in therapy up until 2 years. Obviously, some clients are going to discharge before 2 years, and some are going to continue in therapy more than 2 years. So she just chose 2 years as the cutoff mark. That was all that's required to be part of the study. So it's not like we had a low retention rate for the study, that people dropped out. It was some people, we had a higher number of 100-something that did not stay for the whole study because maybe for various reasons they didn't last 6 months. But people who did the 6-month follow-up and then discharge, they weren't dropouts. Most of them were early completers. They've met their therapy goals much sooner. That might sound crazy to you, but when you're using the trauma interventions, it actually helps speed up the process, because we're using the power of memory reconsolidation. See my recent interview with Nicolosi Jr. about what we can learn from memory reconsolidation research. Don't just take my word for it. Look at Bruce Ecker's research and think, how can that be applied to sexual arousal templates? There you go.
If you heard a therapist claim that I read a study that followed 22 people for 2 years of therapy, and because of this we have large-scale longitudinal evidence that this new therapy is effective, you would likely have a different reaction to the claim than if you were told, I read a study that followed 75 people for 2 years and have large-scale longitudinal evidence that this therapy is effective. And even if all 75 people stayed in the Pela and Sutton study for the entire 2 years, that would only be evidence from a single study of a totally new therapy. It's important to be honest about what we can and can't say from a single study. And we have to be all the more modest when the majority of the participants of a study drop out before the study's completed. And we actually have no way of knowing the eventual outcome of 71% of the original sample's trauma symptoms, mood symptoms, or their sexual attractions. So until more research is done that would indicate that reintegrative therapy does better or is equally effective as trauma therapies in treating trauma symptoms, and show that specific trauma symptoms like nightmares, flashbacks are significantly improved, and demonstrates this through repeated studies with a similar outcome, I would encourage clinicians to address trauma symptoms when present in clients with established trauma protocols that are well researched. Large-scale, longitudinal evidence of reintegrative therapist claims may come, but it doesn't exist from the current research available.
As I've already demonstrated, Julia Sadusky is either ignorant, and maybe willfully so, or she's being intentionally misleading, meaning she might be lying, when it comes to the research design and outcomes in the Pela and Sutton study. I don't know her personally, so I'm going to assume ignorance before malice. And I get it. Reading journal articles isn't fun, and it can be confusing. I hate to do it myself. But, Julia, the ethical and professional thing that you should have done, if you had doubts about the reported results from the already many times over peer-reviewed journal article, was reached out to the lead author, Carolyn Pela, to express your concerns or get clarification. Instead, you ended up going on a very public platform and presenting false information about the scientific data, misleading everyone who looks up to you as a purported researcher and authority on sexuality subjects. For that alone, if you have any integrity, you should remove this video and issue an apology. But then she goes on with her concern about whether or not reintegrative therapy is aiming to change sexuality or just treat trauma. And I can understand the confusion here. This is a very nuanced area of what we do in reintegrative therapy, so I'm going to afford some additional grace when it comes to this part.
A final critical question to answer about reintegrative therapy is this: is it true that reintegrative therapists are not attempting to increase heterosexual attraction and decrease unwanted homosexuality? The repeated phrase of reintegrative therapists is, in quote, trauma treatment is the goal. Sexuality change is often the byproduct. As a therapist who works with many Christian clients who are navigating sexual orientation questions, some of whom have trauma symptoms, I measure outcomes in therapy using evidence-based measures, such as assessments to treat depression, anxiety, and PTSD symptoms when they are present. These measures will tell me whether a person's symptoms have improved over the course of therapy and the primary goal of therapy is met. What I measure is perhaps just as important as what I don't measure. The symptoms or experiences or behaviors I don't measure aren't ignored simply because they don't matter to my client, but I don't measure them because they're not the symptoms that I'm attempting to primarily treat, and they aren't my client's primary goal. What we measure shows what we are prioritizing.
In reintegrative therapy, we do an assortment of assessments for conditions that are typically relevant for our clients. Yes, we do a few different assessments for sexuality and sexual compulsivity, as well as for depression, anxiety, OCD, dissociation, shame, and others that might apply to the particular client. And yes, those measures cover a variety of symptoms that are common to individuals with trauma histories. You're confused about why we're measuring sexuality when trauma resolution is the goal. Well, read that slogan again. Trauma treatment is a goal. Sexuality change is often the byproduct. Well, how can we suggest something might be a byproduct if we don't measure it? And why not measure it? Clients are coming to us seeking sexual attraction fluidity exploration. We don't hide the fact that our therapy is useful for people seeking sexual attraction fluidity, but it's not mere semantics when we tell people the goal is trauma resolution, or you could also say memory reconsolidation. In our content, we repeatedly caution that directly trying to change attraction will actually interfere with the process. This is particularly important for our many clients with OCD tendencies who get fixated on whether or not our interventions will make them straight or not. For anything to be helpful, they need to be accepting of their present state while being open to doing the work and just letting whatever happens happen. This topic came up in the recent interview with Nicolosi following the recent study, one Sadusky didn't mention in her video, showing how reintegrative therapy techniques can change unwanted sexual arousal templates. His client has to be at least well regulated. Like you said, 1 foot in the memory and 1 foot in my office. So they need to be able to look at it. This is part of the assumption of what we do. Like we explain to clients, we're neither taking a pro-LGBT approach or pro-whatever sexuality approach. Maybe if they're dealing with like heterosexual sexual addiction or they're thinking of having an affair. Like we're not going to be pro that, nor anti, where we're like, no, you got to shut it down, suppress it.
Right.
But we tell clients we're taking a curious, mindful approach.
Yes.
Well, some people need help just to get to that point where they can even approach their memories and fantasies with curiosity. And when I explain mindfulness as having mastery of what you pay attention to, and as well as being able to self-regulate while doing so.
Yes.
And some people, they're not even at that point yet. So there's clients I work with, we start to go into a fantasy or memory, and they get so dysregulated right away. I'm like, we're not going to work on this yet until we learn how to just feel our feelings without getting dysregulated. And that might take several months with some clients.
Yes.
And then they can get discouraged because, well, nothing's happening. Well, because we discovered we have to work on this first. We work on that. Then when they reach that milestone, like, now let's do the work that we've been putting off. And then things start to click.
That's right. That's right. That's right. And like you said, everybody's unique. Everyone's journey is unique. Also, there are clients who have moderate to severe obsessive compulsive disorder. Usually mild OCD is fine, but moderate to severe OCD makes it really difficult because they can't really remember the memory very well, or they're off track, or they're too busy judging and analyzing the memory and not able to actually experience the memory because they're holding it at arm's length because they're so afraid of it. And so
Yeah.
those individuals need some more preparatory work. So yeah, that's a good point that everyone responds differently.
Or they're worried like, well, what if I do this intervention and it doesn't change me? And so they get
Yeah.
hyper focused on the outcome. And it's just
Yes.
you need to be in that place where you're open. You have there's this tension or a harmony you got to get to where there's acceptance of your current situation while also striving for more, striving for
Yeah.
growth. And
Yes.
so there has to be an openness to the outcome.
Yeah.
It's
Yes. The paradox of self-acceptance.
yeah,
The change is more likely to happen when you are actually okay with, or you don't have to be approving, but at least accepting of where you are in the moment. Like, okay, I accept this is where I'm at. These are the reactions I'm having. Ironically, that may set the stage for people to see more shifts.
So let's say a client of mine has a diagnosable eating disorder and a range of other behaviors that she would like to be different, including compulsive spending. In therapy, I'm working with her using evidence-based interventions to treat her eating disorder based on my theory of how eating disorders come to be. At the end of therapy, I will be interested in her measuring her eating disorder behaviors, the intensity of eating disorder thoughts, and her feelings about food and her body through assessment and conversation. This is because her eating disorder is the primary diagnosis she's here to treat. And even while I may hear her share at the end of therapy that she has or hasn't gotten a handle on excessive spending, I would not be invested in measuring compulsive spending unless changing that symptom is a goal of therapy. Further, I would not be invested in writing up research articles to demonstrate that compulsive spending was addressed by my treatment of her eating disorder. Or at the very least, I might report changes of eating disorder symptoms and compulsive spending in a research article to show treatment efficacy in accomplishing her and my reported primary goal. If I were to focus my report on compulsive spending behaviors, thoughts, and feelings, it would indicate that what I care about is reducing compulsive spending through eating disorder treatment, not treating the eating disorder symptoms themselves. This analogy is really helpful in illustrating why I doubt the assertion that reintegrative therapists' goal is trauma treatment as opposed to decreasing same-sex attraction and increasing opposite-sex attraction. It seems fair to assume that you measure and document what you care about most, and what reintegrative therapists are measuring and documenting in their research and on their website are shifts in experience of same-sex attraction and opposite-sex attraction, thoughts, feelings, and behaviors, and general mood symptoms.
this is not the own that you think it is, Julia. But I think what I already said is sufficient. But on second thought, I'll add one more thing. Like I said, we do assessments that cover a range of potential trauma symptoms. But let's say we have a client that has some degree of SSA but lacks clinically significant scores on the other measures, like for depression, anxiety, dissociation, etc. Is our treatment approach still justified? Yes. Why? First, because what if it is true that the SSA is itself a trauma reaction? I recall Joseph Nicolosi Sr. sharing at an Alliance conference that he once approached Francine Shapiro, creator of EMDR, telling her about how he had been using EMDR to help clients with SSA explore and resolve their memories and then experiencing a shift in their sexual attractions, and asking her if that was okay. She replied, yes, as long as you're not using it to treat organic homosexuality, indicating that she believed that there were two types of causes of SSA, development and those just born that way. Of course, Nicolosi assured her that he wasn't using it for those who were just born that way. Okay. I also had a professor in graduate school who, despite mocking me for the work I do, admitted that there are people who develop SSA because of trauma. And then there are those who are just born that way, despite the complete lack of evidence from genetics, brain anatomy, and in utero hormones. In fact, evidence isn't just lacking, but the evidence actually refutes the idea that people are born with predetermined sexual arousal templates. So it's perfectly reasonable to me that the same-sex attraction itself is the main or maybe even only reaction to a significant life-altering event or nurture experience. Secondly, a client without other trauma symptoms could still be a candidate for reintegrative therapy because the client could still benefit from our other protocols in reintegrative therapy. The standard protocol is the most trauma-focused one, but we also have protocols to increase mindful reactions to unwanted sexual attractions and protocols to build a more secure attachment style. And just like we discussed in our recent interview, we can use memory reconsolidation interventions commonly used for trauma reprocessing to directly address arousal templates, not just for treating trauma memories. So either way, trauma treatment is the goal, but that trauma treatment can be used not just for trauma memories, but for sexual arousal memories. So all that to say that we are in no way denying that sexual attraction fluidity exploration is a treatment focus in reintegrative therapy. But for all practical purposes, we guide clients to work on relearning their implicit memories and enhancing their self-regulation skills and attachment style. Now for the rest of the video, she goes on repeating the same points that I've already rebutted, so there's no point in playing the last few minutes here. I've been splicing in things from the interview she did with Gay Xtrad, but now there's some remaining segments from that particular video that I need to address as well. Starting with this.
And so what would you say to somebody who they might be listening kind of deep into the Catholic sphere and they're looking for that, well, somebody out there said that I can change my sexuality. I really need it to change so that I can feel holy. What do you do when somebody starts a conversation and already searching for change, believing that it's possible?
It's so easy to mess this up, right? Because we can come in really strong with people, and people listening, this is your experience. You're that person who's really hopeful. Like but they said, maybe I'll be the 30%, right? For whom this could change. And I guess I would first just want to honor the fact that you want things to be different because there's challenges in the experience today. Like there's something that you hope for there to be different, and I want to honor that and say, I want you to be safe in your pursuit of what you're hoping for, while also recognizing it's very unlikely that that outcome will happen. I think the informed consent piece is huge, that yes, you can hope for that, and I'm not here to come in and pop that balloon and change that hope in you, but to maybe set aside that hope next to you and say, what could I do in the meantime, especially if that never happens, to become a more whole, healthy person? Because I think a lot of the disillusionment I see, a lot of the harm I see, is when the goal of change is tied to my sense of inherent value. And what I want to say is, if you're experiencing depression, anxiety, suicidality, these other pieces, can you go and get some therapy to address some of those pieces with a competent therapist who can be respectful of what you're hoping for with attraction, but not move towards a therapy that's offering that manipulation?
Well, hold up. Manipulation? So when I do an exercise with the client that helps them feel free of sexual arousal when they think of a certain memory or fantasy, that's manipulation? Not helping them with their transformation process? Not helping them feel free? Not freeing them from a compulsive habit? That's manipulation. Wow. Okay.
Because if it's going to happen, I think it's more likely to happen through natural fluidity than anything. And so again, I'm not here to pop that for people, but I want to be respectful of that, while also saying, what does it look like to get comprehensive quality mental health care? And many of the providers offering reintegrative approaches, I think, are lacking in some of that ethical, competent care.
Based on what? These are serious charges. Just more baseless slander. This is a woman who has never contacted Nicolosi or any of us reintegrative therapists with her concerns, which is due process in the psychology world. She's never attended our reintegrative therapy trainings. She does not know what she's talking about. Now she goes on to describe her recommendations for sexuality strugglers, to describe their experience as non-judgmentally as possible. I don't really have much criticism of her approach with clients who are struggling to reconcile their faith and sexuality. If she actually cared to know what we actually do in reintegrative therapy, she would know that training clients in a non-judgmental, mindful acceptance of their experience is an essential part of what we do in reintegrative therapy. In fact, some of the more conservative Christians out there don't like our therapy approach because it's not as moralistic, or we don't preach repentance so much. We're like the least behavioral of all the approaches out there. So getting clients to a place of mindful acceptance and curiosity is a prerequisite to doing our reprocessing work. We use sexual orientation neutral approaches, neither pro-gay nor anti-gay. It's one of the things I say all the time in my trainings. And there is research showing that these neutral approaches are considered most helpful by clients with SSA, both conservative and liberal, both non-LGBT identified and LGBT identified alike. See my interview with Dr. Christopher Rossick and my presentation on the 5 streams of counseling for more on that. But the fact is that neutral-only approach can take you only so far. It's appropriate when the client is still trying to figure out things. But once the client is at a place of acceptance and also curious about exploring his or her potential to change, that's where reintegrative therapy is a useful methodology. It's a tool. Use it as it's appropriate. There are some clients with whom I do only exploratory or supportive work regarding their values and worldview. They're not ready to explore things at a deeper level. The client sets the goals, not me. And there are times I hold back on reintegrative protocols because I sense that the client is motivated by shame. I'll say, no, we're not going to do this intervention right now until we get to a place where you accept the outcome either way and you accept yourself. So let's work on that first. That's essential. Their baseline has to be self-acceptance. So this is all why I'm so bothered by Julia Sadusky's videos. Her criticisms are not based in the truth of what we do. And that type of misinformation can unnecessarily discourage clinicians from learning to do reintegrative therapy and discourage clients from benefiting from it. In the gay ex-trad interview, she is asked about the risk of harm in therapy for unwanted SSA. She doesn't even mention the research, namely the Pela Sutton study that showed well-being increase. Nor did she bring up Paul Solon's research that suggests that even in cases in which therapy was ineffective in changing attractions, the clients emotionally improved and had a reduction in suicidality. No, instead, she gives a one-sided critical perspective, particularly by bringing up an aspect of this population that we are all well aware of and address with care: the shame and scrupulosity that they have.
Do you see people that show up to your practice having reported harm from going through a therapy like that?
Absolutely. You know, Cade, what's really interesting about this is there are people I've met with who would not report harm and yet carry a ton of self-hatred, disgust, shame, and then they share about some of these approaches and some of the interventions, and I can see really clearly how they came to experience such great shame and disgust about their attractions. And then there are plenty of people who come to see me after being exhausted by the time, energy, money that goes into retreats and therapy and group counseling and family interventions around these different types of therapy, and they're just exhausted, and they really can't imagine a life in a kind of spiritual life that is sustainable often in the midst of these experiences, because heterosexuality really became synonymous with holiness. And I think once you do that, number one is that cognitively it's so unsatisfactory because the majority of people are heterosexual and do not have the market on holiness. But I think it's just not sustainable to see your attractions as something not only to be held at arm's length, but it has to be gone for me to retain some type of dignity.
There are definitely people who struggle immensely with scrupulosity over their unwanted same-sex attractions, especially those with OCD. This is a major focus in reintegrative therapy. the last thing we want to do is be party to their shame and self-disgust. In no way are we propagating the idea that our clients need to experience a change in attractions in order to have dignity. It's actually quite the opposite. The client is more likely to experience a shift toward their preferred attractions the more he has an embodied sense of his own worth and secure attachment. For a great example of how we try to encourage our clients, check out this segment from Michael Gasparro's second interview with Lila Rose.
How much do you think of healing, along with EMDR and those sorts of therapies, you mentioned it earlier, like the importance of changing the narrative about what happened to you, like the mindset of what happened to you? Because I think so much, I know like Jordan Peterson, a lot of his work is around this, like telling the story of one's life and having a story arc for your own life. Because if your story is set in stone that you are a certain way, certain behaviors you're fated to, your childhood was a certain way, and because of it, you are sort of limited in a certain way. You're sort of have certain obstacles that you will always have. You're going to never be able to, achieve certain things that can change the trajectory of someone's life dramatically. And they might have had a different life if they had simply had a different thought process about what was possible for them. Or about what had happened to them.
I think it's really interesting you mentioned that what helps somebody be able to change that narrative, because maybe most people want to, but they have a hard time. And so one aspect of this idea of healing interpersonally is we need other people to help us see ourselves differently. And that's where both, yes, EMDR and these trauma reprocessing methods that can help people shift the narrative about themselves are good and helpful. And you being with me heart to heart may help me see myself differently and capable of a different trajectory. So I think interpersonal aspects of healing journeys are essential for helping us shake ourselves out of, like, sometimes we don't even know what those narratives are. We're not even fully aware.
We don't even know we're living under a certain narrative.
Yes, until somebody else can help see, like, you're more than that. And they can, and this is what we call a corrective emotional experience. It's more than just knowing it. And I see this a lot with people with SSA in my practice, but also with people with sexual abuse. Some of them are experts on theology of the body. They know their body's a good thing. They have the cognitive awareness that sexuality is a gift, but they lack sensory knowledge, emotional knowledge that it is, because whenever they feel an arousal, they feel shame and fear. And so how do we help people? Yeah, you can change their intellect. You can say, hey, just listen to this story. God made you good, and sexuality is a beautiful thing, and it's a gift from God. But they need an experience that shows them at the sense level, which Aquinas, I believe, says is cognitive ideas include both sensory knowledge and intellectual knowledge. It's called connatural experience. We learn, like with the children, if you have a child and you tell them the stove is hot, they believe you that the stove's hot, but they don't really know that the stove's hot until, unfortunately, they touch the stove and then it's hot, and then now they have sense knowledge.
Of course, I'm thinking, how does this work though with sexual trauma? Because it's not like you can experience sexual trauma and still experience healing without having sex,
right?
Consensual sex. And there is this, unfortunately, there is, again, the kind of prevailing notion amongst progressives who are very to see sex in a certain way that I don't think is grounded in Christian anthropology, but they say, well, you need to just have, that's the argument for you go and have consensual sex, have pleasurable experiences, do self-pleasure to make sex not shameful and to make sex feel good.
People need to with sexual trauma. So we're talking about a particular subgroup of people. So just to be clear, if somebody has this negative experiential knowledge of their own body and of sexuality due to abuse or exposure, etc., that sense knowledge that my body is good, sexuality is a gift, and arousal, by the way, is not a sin. Arousal itself is just a reaction. It's just a pleasure reaction in the body. And this is where we can unpack the idea of what are emotions, what are feelings, how do they relate to the Christian life. But before we go into all of that, pleasure is just a reaction to to sensory and moral goods. It's not a sin. It's an emotion. It's not in the realm of sin. Sin exists in the realm of the will with intent and action. So when a child has been exposed or been harmed in a way that makes them perceive that arousal itself is the problem, that needs to be corrected at a cognitive level, so we kind of provide new education, but there does need to be a sensory experiential knowledge that it's not sinful to feel aroused. And even a friend of mine, Dr. Libby Reichart, who's the dean of academics at St. John's Seminary, she told me she tells the priests in her seminary, her seminarians in her class, she's an expert on aquietist, and she says, sexual arousal is not a sin. It's just a reaction. So then, yeah, okay, so what do we do? Do we do the Freudian thing and say, just go have sex with as many people as possible to get rid of your shame? No, but this is where healing from sexual abuse, we also need to be, as Christians, very patient with people, knowing that as they unearth and begin to feel arousal, sometimes it's a confusing, messy process for people. And I would dare us to try to be pastoral and accompanying people with sensitivity that they might not yet be free for morality to the degree we wish they were yet, and we should not give up on them or shame them for not being where we wish they were at that time. And I'll say one last thing regarding that for children. Some of it has to do with correcting, let's say they're 12 years old and they have this experience and they come to you and they're getting psychological help. No, you don't need to go tell them to do sexual things to overcome shame. But there does need to be an awareness that children integrate their sexual feelings gradually.
Ditto to everything that Michael is saying here. Julia, we would love to hear back from you. You've thrown down a gauntlet with your videos, and we've reached out to you. We would have much rather have hashed things out privately and respectfully, and perhaps come to some mutual understanding. I am not even here to attack your approach to counseling. I think that the approach you take is actually necessary for a lot of clients who are still trying to figure out what they want. But you shouldn't be discouraging clients who actually are at the place where they're ready to explore their potential for change. So I would encourage you to rethink what you've been saying, especially how you're misrepresenting the research and calling us unethical when you have no basis for that. For those of you who are observing this whole conflict, please share your own experience. If you've actually seen a reintegrative therapist, let us know what the experience was like for you. And if you have any other questions about what actually is entailed, reach out. Drop a comment. Reach out to us at Reintegrative Therapy Association. We'd be happy to answer your questions. Therapists who actually want to know what happens, contact us. We're going to be doing trainings this year for basic level and then later advanced level. So we'd be happy just to give you the lowdown of what actually happens in our counseling. That all said, hope you see the passion that I have, but also the desire to be of service to those who really want it. So until next time, please know that Jesus loves you freely, fully, faithfully, and fruitfully. Take care.